Great, and I'll go to play from start. Okay. All right, there we go. So, I'm really excited to be here with Nick and Andy, and we've been having a lot of fun putting this presentation together, and all of us are pretty passionate about this work. I'm gonna start out just by introducing myself and why I started doing this work, and then I'm going to turn over to Nick and Andy to discuss that, and then we'll really get into some of the specifics of what we're talking about today. But I work in a rural emergency department in Northern California. I'm actually there right now. I'll work later. And I started doing this work about 5 years ago, and I do tell folks that I went to a meeting, and there was an outpatient clinic that really was struggling with getting folks in to start treatment. They had a wait list of like 3 months to get folks in, and they wanted to see if we would be willing to give really the right medication at the right time to folks with opioid use disorder. And I came into this, and some of the first things out of my mouth was, well, that's not an emergency department thing. That's an addiction specialty thing. And I said, a buprenorphine, that's illegal to give in the emergency department. I said, aren't there going to be people waiting like down the street for buprenorphine in the emergency department? I said a lot of the things that I think folks think when we talk about this, and I said them out loud, and I was re-educated. And then I humbly decided, I was like, oh, wow, I really need a lot more education about this. And once I embarked on the education, I became very passionate about getting this education out to other folks, because it's been really transformative in my career. It's given me something that I can do for folks when they come in with opioid withdrawal and at post overdose, et cetera. And it's really changed our relationship in my rural community with our community members, and really transformed our connections to outpatient partners. So I'm really excited to share what I've learned, good things, bad things, and work with Nick and Andy, who I've learned so much from. So yeah, that's. But now I'm one of the co-founders, co-principal investigators, directors of California Bridge. I work with Sarah Wendells, who I know is here today. And then we've been collaborating with Michigan, so that we can get this learning out to all of Michigan, and hopefully we can get universal access to addiction treatment through emergency departments in Michigan. So I'll turn it over to Nick. Maybe you can tell us how you got into this work.
Yeah. Thanks, Arianna. So I'm happy to be here as well. It's really an honor to be able to have Arianna and Sarah join us. I came to work and have a passion for expanding access to opioid use, to medications for opioid use disorder in the emergency department, really through a position of frustration, in that I had spent 4 years in Baltimore. I had moved to Flint, and for about 5 or 6 years there, through the early part of the opioid epidemic, when fentanyl kind of entered the scene, it was just a lot of failure. We saw a lot of people with overdose, a lot of people died, a lot of people got very sick, and it didn't feel like we were adequately offering services to the patients that they really needed. And so I know Arianna and Sarah didn't know it, but they acted as a bit of like literature mentors to me, because I was reading about this, program they had in California. They had great resources, and so I got involved by, basically transitioning what they had published into a protocol at Hurley Medical Center, and I think Andy and I were a couple of the first people in the state to do that, which is how I got to start working with the Michigan Opioid Partnership and acting as a technical assistant. So that's how I got here. It's why I love using medications in the emergency department to treat opioid use disorder. And so I'm happy to present today. And if you guys have any questions today or in the future, please do reach out, because it's been a fun journey for me, and I'm happy to help spread that. Andy, do you want to introduce yourself now?
Yeah, I'm just here for the food, man. It's mostly. So, I'm a emergency physician, medical toxicologist, and I do addiction now. And what I had noticed, and what had been going through the medical toxicology community, is that we take care of a lot of overdose, and that's fine and good, but we don't take care of the main underlying problem that a lot of people suffer from. And there'd been a big movement in the med tox community over the past couple of years to really treat addiction in substance use when it comes to us, right? And not a lot of people are very good at it. And so we made or there's not a lot of people out there. There's a big discrepancy between supply and demand. And so we started looking around and noting that, it's a big deal. And we set up, again, ED MOUD programs to be able to identify, screen, and then refer patients directly from the emergency department to care, because that's where the vast majority of them do. Have to just go through, and then some patients that end up admitted also need to have their substance use taken care of, because I think that leads to better medical outcomes. So we do inpatient care there as well. And that's it. Like, it's important. It's one of the most satisfying parts of my job. And I think at the end of the day, from these trainings, we want to be able to give you a new trick, a new skill that you can add to your practice to really change lives. Because, quite often at the end of some of my emergency shifts, it's just, I didn't feel like I really moved the needle on a lot of people's lives. Like their URI would have gotten better, or their ankle sprain kind of would have self-resolved. But these kind of important interventions that you can have can really change the trajectory of someone's life. And that is just increases your job satisfaction 1,000-fold. I didn't really calculate the percent exactly, but it's about that. So I'm happy to be here, and I really love presenting with Nick and Arianna. And so I can't wait to talk to you guys at the end.
Okay, well, let's get into it. So yeah, here's our introductions. We're gonna talk about epidemiology, stigma, waiver. We're gonna talk about the ED role for pharmacology. We're gonna get into all of these things, but I want to say that this is also interactive. So we would love to hear from you. We work in emergency departments. We get really uncomfortable. The Q word, when it's like really quiet, which I just said that in my emergency department, which I'm pretty sure set me up for a terrible shift. But we would love to hear from you. We're at the end of each of our segments, we'll do a little discussion. And you don't have to say anything any particular way. You can ask questions just as you are. So I just want to put that out there. We'd love to hear questions, concerns, things like that from you. So, all right, so I'll just get into this. I actually got this slide from Andy, and this is really it for me. I did this. I did the best I could until I knew better. And then when I knew better, I did better, right? So yes, this is from Maya Angelou. We can learn from this. I think this is something to carry with you in medicine, that we do the best we can with the information we have at the time. And then when we learn something different that is better, and that we know that will provide better care for our patients, we need to really make the change to improve care. And that's why we're here today, is to discuss that. So learning objectives today, we're going to define opioid use disorder as a medical and public health emergency. We will explain that medications are the most effective treatment for opioid use disorder. We'll recall pharmacology of buprenorphine, naltrexone, methadone, apply principles of precipitated withdrawal, and we'll demonstrate how to diagnose someone with opioid use disorder, and summarize how to start someone on buprenorphine in the emergency department. Bottom line, how do we do this? So let's get started. All right, so traditionally, we'll talk about some of the verbiage we're going to use here, but traditionally you've heard this called MAT, medication assisted treatment. We've changed that a little bit because it really does sound, kind of like you're way above somebody and we're going to assist you here, and that folks need assistance. So a lot of folks use the terminology medications for opioid use disorder, or MOUD. So they hear us say MOUD, and that's not the mood we're in. That's giving medications for opioid use disorder. You might hear opioid agonist therapy. That's in a lot of publications that you'll see it called opioid agonist therapy. And what we use at California Bridge frequently is medication for addiction treatment, because it keeps it in that MAT world. And we also actually give, now that we've started with opioids in my department, I give medication for stimulant use disorder, folks who are struggling with methamphetamine, folks who are struggling with benzos, folks who are struggling with alcohol. We have all sorts of different things that we do now because we figured out we could do better. All right, so people are dying from overdoses. So this is not, this is certainly a national thing. This was actually from January of 2022. I did a quick update to see, where we headed, and we saw a 20% change in the last 12 months of drug overdose deaths around the country. And unfortunately, Michigan was not spared this. So Michigan saw an 8.6% increase in overdose deaths, but actually even in the last few months, we think that's even been greater. a report actually just recently came out that noted that there was more than 107,000 deaths in the last year from overdoses, and more than 80,000 of those were related to opioids. And this is the problem. So those age 12 plus, yes, age 12 plus, actually addiction by definition is a pediatric disease. A lot of folks start, unfortunately, in the ages between 12 and 18. But of those who need treatment for substance use disorder, only 10.3% received any treatment. We have this huge gap in treatment. So almost 90% of folks who need treatment for substance use disorder actually receive it. And I just boiling it down to Michigan, overdose deaths in Michigan month by month. You can see that the green line is 2019, the tan line is 2020, and the blue line is 2021. And across the board, we're just continuing to see these increased overdoses. So in these increased overdose deaths, and I really, out here in California, it's been the same, and we really feel it here in the emergency department. Where do overdoses go? They go to the emergency departments, right? So we've been seeing a lot of this on a day-to-day basis. And just so you can see, maybe you can find your county here. This is the top 10 counties with the highest fatal opioid overdose rates in 2019. And you can see those top 10 counties, and these are significant overdose rates. And I also just wanted to, when I looked at the Michigan Department of Health and Human Services, the opioid strategy, when I looked at it, I realized the emergency department is just core to so much of this. And even unspoken here is when emergency departments do this work, it creates this safety net for other folks in the community to do the same. So it's really this sort of butterfly effect that you can see when the emergency department is taking this on and develops expertise in this. Because imagine if you're a primary care physician, you're out in a rural part of Michigan, and you want to start this because you know it's the right thing to do. You've seen these slides, you know that there's evidence, and you want to start treatment. But if your emergency department's on board or is not on board, and you start somebody on buprenorphine, they end up in the emergency department for whatever reason, and there's not that shared understanding of how to treat opioid withdrawal and opioid use disorder, you can imagine how that might cause some harm, and that might cause issues with your patient getting the right treatment. And just having that disconnect really is confusing to patients. So turning the tide on the opioid epidemic absolutely requires the emergency departments to engage. And again, we circled the parts of this strategy where emergency departments are key: increasing treatment capacity, having all these emergency departments who are increasing capacity, streamlining treatment access, improving post-overdose care. And we'll talk a little bit more about how important that is. Expanding and targeting naloxone distribution. And I know that there's a lot of, there's programs for increasing and expanding naloxone distribution in Michigan. This is key. Every one of my patients post-overdose is getting naloxone in hand to go home with. We've had, just in my rural emergency departments in the last year, we've had 22 patients whose overdoses, whose deaths were reversed by naloxone that was distributed from my emergency department. And we know because we put stickers on them. So we can increase treatment access. We can improve, the emergency departments are unique because we can actually also improve care for pregnant women and substance use disorder, because being that open door, we see everybody, we're that safety net. And then we can use and share data to inform the response. We can share what we're doing. We can share the stories of where we were able to provide treatment, not only with our hospital, with our emergency department partners, but with our communities. And this is really important. So this is not uniquely an urban problem. Yes, we see large and steady increases in overdose deaths in large cities. A lot of this is related to fentanyl, and I'll show you that. But we're also seeing increased overdose deaths in more rural locations. And there's frequently a lack of any treatment access at all, or any X-waiver provider at all in a lot of these rural communities. So again, establishing this treatment in pre-existing infrastructure in the emergency department saves lives. So important in all settings: suburban settings, rural settings, urban, academic settings. It's incredibly important. And this is not something that needs to be relegated to addiction psychiatry. I mean, I don't have any addiction psychiatry in my entire county. So if that were the case, then folks would have to leave my county in order to get treatment. And that can be extremely disruptive to their lives and not necessarily give them the best chance, maybe if they really want to engage in treatment while they're with family, et cetera. So it's really important to provide this from any setting. And then again, when we really dig down into these overdose deaths, and I'll show slides like this repeatedly so you understand where this is coming from, but you can see this increasing, this is in the United States, this increasing overdose deaths, right? You see this from really increasing significantly through the pandemic as well. So if you look at the various lines, you can see, you know, methadone, you're really down at the bottom, right? And methadone is a great treatment for a lot of folks too. We talk a lot about buprenorphine here, but methadone is a great treatment for a lot of folks, and that works for a lot of folks. I don't have any access to it in my community. It's very difficult to access. And in the emergency department setting, we found buprenorphine is really helpful. But what I really want to drive home here is you see that like brown line that's like just going parallel with those increased overdose deaths. And that's synthetic opioids excluding methadone. That's fentanyl. And fentanyl is the only thing that folks can get in my community right now. And it's not just in opioids. So we're seeing a lot of fentanyl contamination in multiple street drugs. A lot of, in fact, a lot of kids think they're getting, you know, they're getting alprazolam or they're getting benzos, and it's fentanyl. So this is really driving these overdose deaths. A lot of folks think they're, you know, they may be using stimulants, methamphetamine, and it's fentanyl. So we do see, we see fentanyl deaths, not only in folks who use opioids intentionally, but for those folks who don't realize they're being exposed to any opioids. And when we look here at overdose deaths in Michigan, and really this is actually Detroit compared to Michigan, you can just see that these opioid overdose deaths are really skyrocketing in Detroit in particular. And when we look at these overdose deaths by race, huge disparity here, right? So in Black African American population in Detroit, you can see this huge spike in overdose deaths compared to to white, to other unknown. It's this enormous issue, and a lot of this has, when we dug into this in California, we actually have done a zip code analysis and looked at access to buprenorphine treatment, and we'll talk about why buprenorphine treatment can be really helpful here. But there's decreased access to buprenorphine treatment frequently in urban communities, and decreased access specifically in our Black American population. So it's really important to close this gap in treatment here, and emergency departments are prime locations to do that because we can provide immediate access. We don't have all sorts of crazy rules to get in. You just, no shirt, no shoes, you do get service. So, you can show up as you are. You don't have to have the right insurance to show up to the emergency department, the right ID. So we've been able to, we're trying to really close these gaps in care and really close these disparities in access to care through the work we're doing in emergency departments, and then provide excellent referral to treatment. So why, this is a slide I show frequently. Why are we always talking about buprenorphine? This like really long word that's hard to say. I know when I tried to say it, Andy, I think, says it really well. He like buprenorphine, do we call it bupe? I've heard people say, what's that word? So anyway, I know it's hard to say, but now it rolls off the tongue, maybe, I don't know. But the reason that we like treating with this medication so much, and like I said, buprenorphine, methadone are both very effective. And this is actually a study that looked at both. But you look at death rates. So these are standardized mortality ratios. So you look at death rates in the general population. And then if you look at folks with opioid use disorder with no treatment, you see these enormous increase in overall. This is in all-cause mortality. There's different reasons for significant increases in all-cause mortality. So I showed you a couple slides about overdose deaths, but there's also increased all-cause mortality. This is related to infectious disease, HIV, Hep C, increased violent crime deaths. There's a lot of chaos involved when, certainly with folks who are struggling with opioid use disorder. And so there's in other infections, there's folks with endocarditis, just a lot of comorbidities. And we see this increased mortality and morbidity. But when we get folks stabilized on treatment, we significantly decrease these death rates. And in fact, we decreased their death rates by more than 50%. So this is a sublingual medication that we administer in our emergency departments. And we're able to make this enormous difference by giving the right medication at the right time. I call it the nursemaid's elbow of emergency addiction medicine, because we can give a medication that's very easy to administer. I literally administered this in my lobby yesterday when we were experiencing a super crazy shift. We had no rooms. We had 3 times the amount of patients that we can handle. And I was able to administer this to somebody in my emergency department lobby, because it's a very easy medication to administer. So again, this medication makes a huge difference and is very easy to administer. So I know a lot of folks will tell me, I don't do this because I don't have an X-waiver. So number one, you can do this without an X-waiver in your emergency department right now. You do not need an X-waiver to administer this medication in your emergency department. It's way more effective to prescribe it. And again, we will continue to talk about this, but I just want to get this out there because I think a lot of folks miss this. You do not need the education requirement in order to get your X-waiver anymore. So this is to treat up to 30 patients at one time. And I love doing this work, and I will treat as many folks as I can treat. And I will never treat more than 30 patients at one time in my emergency department with buprenorphine. So you can go, I have a slide where you can start getting your X-waiver like right now, because it takes 5 minutes. You just need your DEA number. And we have a step-by-step guide we can show you, but getting your X-waiver just makes this easy, because if somebody's not in withdrawal, you can prescribe it. If access is difficult, you can give a prescription for a longer period of time. There's different rules in different states. In my state, all PAs and nurse practitioners work under a physician's license, but we also do not require our physician to have an X-waiver. Different states have different rules. And it's no longer required to offer counseling or other ancillary services to folks to give buprenorphine. So again, everyone submits an application through the SAMHSA website, and you're doing a notice of intent. So if you get nothing else out of this today, get your X-waiver today. You can do it if you're bored during our talk here. Here it is. Here's a QR code. We all do this at restaurants. You pick the menu, so you can use this QR code and you can apply to get your X-waiver. You can do this right now. All right, so why are we getting our X-waivers right now? Well, this is a reference from Michigan. This is like average waiting time to get into substance use disorder treatment. Now, we'd like to normalize this so everybody can do this, right? But there's folks who have this moment where they say, okay, this isn't really going well, and I'm in withdrawal. I don't have money, and I'm going to have to steal in order to get this. Or they have a crisis where they say, I just feel like, what if there's fentanyl in it? My friend just died from a fentanyl overdose. I want to get treatment. And what if we actually make everybody wait these 6 days, the 6 days on here? You lose the moment. They have to go. If they don't get treatment, they have to go at that moment and get more drugs, or else they're going to get really, really sick. They're craving this like oxygen. So if we're not able to provide treatment right at that moment, when a person says, this is it, I'm ready. And again, I just treated somebody yesterday who had that moment, came in with his mom and said, okay, this is like, I don't ever want to buy drugs from this dealer again. I really want treatment. And I was able to start him right at that moment. What if I didn't? And told him, I'm sorry, it's going to be a week. We lose so many people out, to the community who don't get treatment, who we make wait these 6 days. This is an emergency. It's important to treat it as such. And folks are already in your emergency department. They're there right now. Like right now, if I look at the board in my emergency department, I can tell you, when I really dig into some of the chief complaints, 28% of adult emergency department patients will screen positive for a substance use disorder. And in 2019, only 18% of those with opioid use disorder were actually receiving any medication for it. And we know that this works. So there's supply, there's demand. We know these folks are already in our emergency departments. You may think, I don't have this issue. I actually said that out loud. I said that. I told you there was that first meeting. I said, oh, I don't have a problem with opioid use disorder in my community. And then I actually looked at statistics and I was completely wrong. So this is the reason that this is an emergency as well. This is important to know. So you see people who come in with overdose. I'd have you raise your hands, but I can't see you all. But how many of those folks leave against medical advice? So right after they're reversed, they feel terrible and they're like, see ya, I'm out of here. We know that 1 in 20 of them will die within a year. These are 20-year-olds who will die within a year frequently, right? So 1 in 20 will die within a year. And oops, let me go back here. So there's a significant 1-year mortality of patients after emergency department treatment. So 16% of patients obtain follow-up treatment after a non-fatal overdose. That's dismal. My follow-up rate is right now over 80% and at one point 97%. And again, that 1-year mortality is between 5 and 10%. But I want you to look at this graph and look at that first line. So that's just within the first day, the significant spike in overdose deaths after a non-fatal, a reversed overdose that comes into your emergency department. And if those that don't get treatment are in our more vulnerable populations here. So we have standards of care in my emergency department where we give in-hand naloxone, where we offer buprenorphine and referral. Really important. This is a really big emergency and one that we can do a lot about, especially after these non-fatal overdoses. And we also know when we give treatment, this is an RCT study done by Gail D'Onofrio at Yale, published in JAMA. And this showed that we can double a patient's likelihood of being in treatment in 1 month by just giving buprenorphine in the emergency department, administering it in the emergency department. So buprenorphine under the tongue in the emergency department. The follow-up rate at 1 month was 78% of folks were in treatment versus 37% of folks who did not receive buprenorphine and just referral alone. So again, giving the right medication at the right time doubles their likelihood of being in treatment and also reduces the risk of dying from any cause by more than 50%. And we can reverse that trend of overdose deaths after a non-fatal overdose. So the bridge model, something that I talk about all the time, what we've been trying to do in California is create universal access. And I know we're trying to do this in Michigan. So just giving low barrier treatment, come in, we give you the right medication at the right time. We connect you to outpatient care and to community resources that are out there. We make sure we know what's going on in the community and the right resources, harm reduction. We have harm reduction in everything we do. I've changed my language, how I approach patients. I've taken courses on motivational interviewing. We do naloxone distribution. We have sterile syringe access, really taking this whole culture of harm reduction. And I do this in everything I do now with every patient, from patients with diabetes to patients with substance use disorders. It really has transformed my practice. And really the overall goal, and again, this patient I treated yesterday, we want to make it easier to get buprenorphine medically than street access to drugs, because the scale has been tipped the opposite direction for so long. A lot of my patients can tell you way easier for them to get drugs on the street than to get treatment. And we want to tip these scales so that folks have access to treatment and make it easier than street access to drugs. So, and we know, again, the effectiveness of buprenorphine. This is something we'll continue to talk about, but number needed to treat, I'm a simple person. I like to talk about number needed to treat. It's a simple number, and number needed to treat, for antihypertensives to prevent heart attack, stroke, and death, 1 in 125, 1 in 67, 1 in 100, right? But number needed to treat with 16 milligrams of buprenorphine, which is our standard treatment daily to retain in treatment, is 2. The number needed to treat is 2. And the number needed to treat to prevent death is 40. So we still have significantly improved numbers here by giving this medication. And then again, you'll say, well, what happens? And this question was asked of me just the other day. What happens if we just flood the community with buprenorphine? Well, you can see as buprenorphine, which is that dotted line that's going up there, as buprenorphine doses increased, and this is a figure from Baltimore, Maryland from 1995 to 2009, a study that was done. That red line is heroin overdoses. Those overdoses went down. And we can also see that methadone was increasing in that time too. So both methadone and buprenorphine, we can decrease these deaths when we look at this in multiple settings. And in France, they made buprenorphine available without an X-waiver. So you can go into a pharmacy right now in France and you can say, I have opioid use disorder, and a pharmacist, they make it very easily accessible, one-stop shopping. And the dark line there is heroin overdoses. The light line there is patients giving buprenorphine. So as you see buprenorphine go up, you just see those heroin overdoses go down. And they did this because they were actually doing this initially because they were experiencing a lot of overdose deaths, but also HIV transmission in folks who were injecting drugs. So these 3 waves in the rise of opioid overdose deaths, this is significant. We had the reason I show this is I just wanted you should know that we had a hand in this, right? Wave 1 was prescription opioid overdose deaths. I've worked for 22 years. I was a part of this. I was over prescribing. I work in an emergency department, so I don't give lots of it, but I'm sure giving this unnecessarily, and especially to some teenagers. This is a really ripe time for that. We have to be very careful. So we were giving this out like, just like Tylenol or ibuprofen. And there's a lot of factors in this, multi-level approaches. And I know emergency departments were not the center of this, but we had a hand in this. But first, increased opioid prescription deaths, then rise in heroin overdose deaths. And then again, this is fentanyl overdose deaths that started in 2013 and unfortunately has just taken off. All right, so we have different medications. I've mentioned some of them. There's methadone, there's buprenorphine and naloxone, there's naltrexone. And what I can tell you is, the naltrexone I only use for alcohol use disorder because it's really hard to get folks to naltrexone. That's but it works very well for my folks with alcohol use disorder. But really, we give buprenorphine with or without naloxone. The naloxone component, people ask me this all the time, and I'm sure Andy and Nick will talk about this more. It's just there to act as a deterrent. It's not active if it's used as directed sublingually. If it's injected, then the naloxone component becomes active. And then again, methadone is still a good medication. There's just a lot of regulations and it can be difficult to access for some folks. All right, major features of buprenorphine. And I think I'm getting close to the end of my, here, I just have this in that case and we'll have a little quick discussion. But again, I just want to highlight this. The reason we like this so much is buprenorphine is a partial opioid agonist, and it has a ceiling effect on respiratory depression. So as compared to full agonists, morphine, methadone, heroin, fentanyl, hydrocodone, we know that buprenorphine is safe because it has a ceiling effect on respiratory depression and sedation. There's not really a ceiling effect on analgesia. And the other thing about it, it has a super high affinity for the mu receptor and it blocks other opioids. So if I load a patient with enough buprenorphine in my emergency department and they go and find fentanyl in their glove box, right? This actually happens. And they use it, the buprenorphine sticks stronger to that. So then they're just wasting money and drug because it's not as effective, right? So, and then it also has a long half-life. The only problem with buprenorphine is it can displace other opioids, and this is called precipitated withdrawal. So you see that gray arrow there. If we give buprenorphine while somebody has full agonist opioids on board, unfortunately, we can precipitate withdrawal and put them into withdrawal because there's this difference between it, because buprenorphine is a partial agonist, partially activates that mu receptor as compared to the full agonist that was on that mu receptor. So we give folks buprenorphine when they're in significant withdrawal. But again, we love the half-life. It's 24 to 36 hours. I can extend this sometimes by giving even higher doses. And you could do this 2-day, even without your X-waiver. You can administer it in the emergency department. But again, I'm sure you're on your computer applying for your X-waiver right now so that you can prescribe it because it's easier. So I'm going to give you, we're going to talk about a case. So here's Sophia. Sophia comes into the emergency department. She comes in, 28-year-old female, severe abdominal pain. She's diaphoretic, tachycardic. She comes in and she's not sure she can tell you she's actually in opioid withdrawal, right? A lot of folks have been stigmatized. So she might not feel safe. Maybe the last time she came to the emergency department, she heard somebody calling her a junkie. She heard somebody talking about her as if she's a lesser human. So she comes in, she decided to quit using opioids, but she's just super sick. And she's like, she's shaking. She's like hunched over like this. She's really diaphoretic, tachycardic, right? So she's trying to quit using oxy. She thinks there could be fentanyl in it, but she's experiencing these severe withdrawal symptoms. She's tried to quit before, but couldn't make it past day 3. She made it to day 3, but at day 3, she's like, I'm out. This is too hard. So when you look at her, she's irritable, she's diaphoretic, she's restless, she's yawning frequently. In fact, the triage nurse is like, I don't think she's that bad because she's just sitting there yawning like she's bored. She's got a runny nose, goose-flesh skin, nausea, diarrhea. She's a tachycardic at 108. She's vomiting actively. So if she actually didn't disclose the oxy part, what if she just said, chief complaint, abdominal pain, and she looks this bad, right, in triage, what would you do? I know if she didn't disclose this to me and she looked really bad and was hunched over and diaphoretic, and tachycardic, I would, start an IV, saline boluses, labs. Maybe I'd get a urine drug screen because I wasn't sure. Maybe my triage nurse said, I don't know, I think something's going on. Maybe I would get a CT, abdomen pelvis, because, I thought she had an acute abdomen. So she comes in the emergency department, and this is somebody that we see very frequently, right? This is a pretty common case. We initially, this actually happened 5 years ago in my emergency department. Full workup with labs, IV, CTs ordered. She's experiencing the severe abdominal pain. Didn't initially disclose her opioid use. We actually started putting these signs on the wall that said, we'll treat opioid withdrawal with medication. Are you struggling with pills or heroin? So we put these on the walls, and maybe Sarah, you can share that in the chat. But so she sees those signs on the wall, and she says, oh, just so you know, like she's miserable. She's like, I just have to admit, I've been struggling with oxys. And they were trying multiple IV attempts, right? So I'm embarrassed to say this, but I think she had 6 or 7 at least IV attempts because they couldn't get a line. So so instead of going that route, we sort of said, oh, let's change plans. We had a discussion, and we talked to her about buprenorphine. So we gave buprenorphine 8 milligrams, with no IV, no labs. And we checked her after 45 minutes, and she started to feel normal. We gave her a second dose, and all of this huge workup was canceled because we just gave the right medication. We discharged her home with in hand naloxone, prescription of buprenorphine. She actually left the emergency department, hugged the nurse, and said, you saved my life. That nurse is now the biggest champion of buprenorphine at my emergency department. She followed up in clinic, continued buprenorphine, still in treatment 7 and 30 days. And we shared that information with the nurse, with our whole staff, because this was really important. All right, so I know that there's a lot of chat, and I haven't been able to look at the chat because I've been presenting. So I'm going to stop sharing my screen and look, and then we'll transfer this over, and then we'll start the next part of this presentation. But any good questions here? Nick, Andy?
A lot of good questions. One of the first ones was just broadly, why would people that sell drugs, lace something like a benzodiazepine or MDMA or something with an opioid? And so I don't know that we came to a conclusion, but a lot of it's economics. I always think it's partially just that drug dealers aren't like pharmacy inventorists, right? And so they're not great about keeping their pills straight, and sometimes they just mess it up. But maybe there's something else as well.
I think that there's just so much fentanyl that it's easy to do if you're trying to make a pill of something that's going to, change your mental status. That's an easy thing to just reach for, just because it's so common right now. And if you're trying to make a benzodiazepine, it's like, well, just add a little fentanyl in it. You can press it, and you can add some, I don't know, drywall material, and then you have yourself a drug that somebody can use. And it's extremely dangerous, and it's not really well metered. Like I totally agree with that part. Like they're not metering things as well as they should, right? Like, but that's my best guess. I should start. And there's like some. There you go. Sarah put that up. There's some insights into what they're doing that. But Canada is like they call it like the benzo dope or the benzo something that's going on, and Canadians are seeing a lot of that be a big problem too. And being in Michigan, we're really close, so yeah, that's a big thing.
Yeah, I was gonna say there's also the whole withdrawal part. Talk about making a loyal consumer. If you actually literally get sick. Now we know with benzos, folks seize, if they stop using, but like specifically in methamphetamine, you kind of sleep it off, right? But if there's fentanyl in there, you're going to get sick if you don't use. So you're going to need to go get more. So there's some ideas that could be playing a part in this as well.
Cool. Then the other question was about these new go packs that recently got approved by the DEA. So it used to be that you could have patients come back for 3 consecutive days to the emergency department without an X-waiver. You could give them buprenorphine in sight. And they recently said that they'd expand it and allow us to do these go packs where you could send someone home with 3 days. I know Arianna, Andy, and I had a conversation about this, and Sarah as well, about how that's a great idea, but we found it to be technically challenging just because of pharmaceutical restrictions about controlled substances. Yep. But we do have some Michigan Opioid Partnership is bringing on a pharmacist as a technical assistant. So if anyone has any questions, anyone that wants a pharmacist to talk to their pharmacy team, we're happy to do that and try to work around some of those barriers. I'm gonna take over and start my slides if that's okay. Okay, so thanks everyone for coming. So we just had, I think, a pretty good review about some of the success and why it's so important to offer medications, and specifically buprenorphine in the emergency department. The problem right now is that there is this huge gap in what is offered and what is available and what patients are able to get. So we know that medications are the most effective treatment, but only about 30% of these outpatient programs that we probably regularly refer people to are offering the medications with maintenance that is most effective for them and is going to offer the best long-term effect. About another 30% offer short-term medications with then a detoxification within a detoxification period. And we know that this actually can increase mortality because you go through a detoxification, you then have a period of abstinence, your tolerance is gone, and then you abruptly overdose because you go back to using the dose you're using before, which is now too much. So, but 30% of these places I think we often refer people to do offer this method, which is not great. And then about 40% do not offer medications or are unclear about it. This was a telephone study where research assistants called listed drug treatment programs. And then about 20% of those programs actively discourage those callers when they asked about medications as an option. And so I think the real point of this study, number one, is there's not enough high quality evidence-based outpatient treatment programs. And number two, know what your sites, your referral sites are offering, because you don't want to go through a process of installing a medication pathway for your emergency department. And then your rapid follow-up is to a place that does 2 more weeks of buprenorphine, it does a taper, and they're done, because that's just not what the evidence supports. And it also goes for any counseling services and even like peer recovery coaches. Sometimes people will be very focused on like a medication-free pathway, and those we just know are not successful and can actually set people up to overdose and die when they stop using medication or drugs and then go back to using. The benefits of medications, buprenorphine, methadone, naltrexone, is that they do decrease the use of illicit opioids, but they also decrease overdoses, deaths, infectious disease, so hepatitis, HIV, and then all-cause mortality. And so we know that all-cause mortality is, depending on the study, anywhere from 6 to 20 times higher for those that use IV drugs, and medications basically move it down to about twice the population that doesn't use IV drugs. So we, as emergency physicians, are, and maybe APPs as well, are very important because we are available. We are always open, and whenever someone needs help, they can get it from us. And the other reason is that we can often see patients at an inflection point in their life, right? So after they overdose, it's actually a very good time to talk to them about maybe time for change. This is a time when they may be receptive to hearing about treatment options because it's a vulnerable period for them. We also know that they come to us for their wound infections, endocarditis, cellulitis, abscess. So we see them when they're not even seeking treatment. And so if we know how to kind of capture and engage people, then we can be a really important place for people with opioid use disorder to get access to treatment. The other thing is people have other medical and psychiatric complications, and we're good with this too. So if someone has depression, is suicidal, has an opioid use disorder, we can either engage them in treatment then, or we should continue their medications. And so we can both be a site where good medical care is continued or where it's initiated. So we play a lot of different roles, but it's very important that the emergency department and everyone's community is really familiar with how to treat opioid use disorder with buprenorphine. Saying all of that, there are still these deserts and areas in the community and around the country where treatment just isn't available. in one of our other presentations, there's a big map of Michigan, and there's plenty of access in parts of the southeast part of the state. But when you get up into the northern counties, Upper Peninsula, you can, potentially have to drive hours to get treatment. This is also true regionally in the country. Per capita, there is a lot more prescriptions for buprenorphine in Vermont compared to South Dakota. And within that, you also have these barriers where in different parts of the country, pharmacies will either, deny or discourage people from initiating medications. And so it's really important to be aware that these gaps exist, because say someone is visiting family or friends, you see them in the emergency department in Detroit, but they're from, the Upper Peninsula, they may have to work harder to find someone to follow up with. And when you're building your program, it's good to make a good relationship with pharmacies that have buprenorphine and aren't going to discourage your patients from continuing treatment. Another place that there are often treatment deserts, but should actually act as a doorway to treatment, are jails and prisons. Just like the emergency department population, those who are in jail and prison have a higher rate of opioid use disorder than the general population. But unfortunately, they're undertreated. And so we see that only about a third of patients with opioid use disorder get medications. And this is usually even a continuation of their treatment. So they do very few initiations generally. And sometimes I've had, discussions with people that are hesitant to start medications, and they'll tell me it's because they have a court date in 2 weeks and they think they're going to jail. So why would I start buprenorphine if I'm just going to go to jail and they're not going to continue it anyways? And so, another point to press on in your community, maybe talking to your local jail and prison facilities and seeing what they can offer, what they're doing, because maybe you can reassure that patient that, oh no, they'll continue it, or know that if someone's going to jail, they can even start there. So you can know what your local resources are. So what we know is that low barrier access to treatment is extremely important. Traditionally, in order to prescribe buprenorphine, you had to also be able to offer behavioral health sessions to refer to counseling. And this requirement was removed when the educational requirement was removed in April 2021. So you no longer have to have direct access to counseling in order to start someone on buprenorphine. And you don't need a drug screen. So sometimes it's helpful to get urine pregnancy tests and urine drug screens after someone started on buprenorphine and they're feeling better. It can help with their outpatient follow-up to see if, if they're testing positive now for cocaine, methamphetamine, and opioids, that in 6 months, they're no longer testing positive for cocaine. Maybe they're still testing positive for methamphetamine. You can say you had success both with their cocaine and their opioids. They still need to work on their methamphetamine. It's not that important. The most important thing is that they, number one, start on buprenorphine so that they don't get sick. And if they use fentanyl, they're unlikely to suffer harm from it because those receptors are blocked. And then the second most important thing is that we decrease opioid use in the community. But primarily, we just need to get people on medication so they're protected from unintentional overdoses. So the no wrong door approach illustrated here. So we, as the emergency department, can be one point of entry for medications. We would love for other locations, community mental health, jails, prisons, to also be sites. But right now, as the emergency clinicians, we're focused on doing everything we can. I'm going to take a quick minute to talk about a little bit of stigma, because I think truly doing this work for a couple of years, talking to a lot of people around the state, there are a lot of concerns about doing this that I think are just rooted in stigma, and some things that really don't come to fruition when we've done this. And so hopeful to make everyone feel a lot better that this is going to be safe and easy to do. So number one, people, rightly so. Remember, this used to be an 8-hour educational session, And now we're doing it 90 minutes. So it used to be that if you were a physician, you had to take 8 hours of training before you got your X-waivered. That went away last April. If you were an APP, it was 24 hours. And so really the best thing is that now APPs can get access to prescribing buprenorphine without this huge barrier. There is concern that it will take a lot of time in the emergency department to start them on medications. And actually, as Arianna's case illustrated, the inverse is true. It is much easier for someone with a history of IV drug use to not give them IV medications, to just give them sublingual medications with really no requirement for any labs, maybe these urine tests. The conversation is not that difficult. They simply sit down, ask permission to talk about their drug use. When did they start? How do they use? We'll talk in a second about how to make the diagnosis of opioid use disorder, but I'll go through some of those checklists. And it's a 5 or 10 minute conversation, do a little bit of motivational interviewing, check them for readiness. And then the truth is that most patients have had an experience with buprenorphine, either through a formal treatment pathway in the past and they fell out, or using their friends' medications. So it's kind of rare at this point when someone doesn't have any idea what you're talking about. So that does make these conversations much quicker. And then sometimes we hear, oh, emergency department, I just see them for a short period of time. This is a long-term disorder. It should be in a clinic. And part of that's true. But to get them to that clinic safely so they can get into long-term treatment requires that we have a short-term intervention, which is initiation and then a short-term prescription. Plus, we're pretty good at delaying gratification as medical professionals. It's been a long haul for many of us, and for our patients, if we don't see the benefit for them in 6 months, I think that's something that we're all used to doing. There have been a couple qualitative papers looking at attitudes of emergency clinicians for opioid use disorder treatment, and it does run the gamut. On one end, you'll hear a lot of people say that this isn't the place for opioid use disorder treatment, that it's too time consuming, as we talked about, that they're worried about diversion, which we'll talk about later. They're worried that they're just feeding into bad habits. But on the other end, you see there's recently been a tide that has changed because I think more and more emergency departments are doing this. It seems like the literature is full of papers showing the success of these pathways in the emergency department. And most importantly, last September, I believe, the American College of Emergency Physicians put out a position paper saying that emergency clinicians should be providing buprenorphine to patients in the emergency department with a prescription. And so now there's a national society guideline. And so it's becoming more and more standard that this is being done in our emergency departments. People worry about ability to follow up. It often takes, some conversations with your local resources, but if you have a grant through the Michigan Opioid Partnership, let us know. We have plenty of people that can help you obtain follow-up, a good treatment pathway for your system. We hear that patients may not have insurance that covers it, and they may not have insurance at all. So almost all, I don't know of any private insurance that doesn't cover buprenorphine. I know that Medicaid, Medicare covers it. If you don't have insurance, then you have to pay in cash. If you use a GoodRx coupon, it's typically $30 to $40 per week, which is always cheaper than the heroin they're buying off the street. So that's a little bit of leverage you can use, because sometimes these concerns come from the patients as well. And knowing that it's going to save them money to be on a medication can sometimes be helpful. We sometimes hear that emergency departments are so busy they can't possibly offer a service such as offering medications because it will just drive their volume up and they won't be able to handle the extra volume. And that's also not the case. I think, so I now work in Grand Rapids. I was at Hurley Medical Center. For both sites, it's been pretty similar. We get I don't know, 4 to 10 inductions, depending on the month. And it's not something that is going to, spike your volume. If anything, it increases throughput because, patients don't need a full workup for their abdominal pain that you can't figure out. They can be started on medications. And then it also helps with patients who are there for psychiatric hold. They're not getting agitated and violent and needing chemical and physical restraints because they're going through opioid withdrawal and you're not treating it. And so it does, I think, make the quality of the ED experience better and not worse for both staff and patients. There are 3 different studies. I know Arianna has really good follow-up with her group. This study on the top here showed the 75% treatment retention at 30 and 60 days. That's not been my experience. Mine is really closer to probably 40 to 60%, depending on the site. But it does, it varies on patient population, on ease to access to your clinic, on how readily available your recovery coaches are. So know that you can expect a high level, but you shouldn't expect a medium or even 30% follow-up to be a failure. These are, again, young patients with a extremely morbid disease with a high mortality rate. If you can get 30% of them to no longer be at risk for overdose and death, that's still a success. We should aim for higher, but even 30% would be a great success. So how do we do it? It's actually very easy. Number 1, through your history and exam, you should try to diagnose opioid use disorder. We'll go through the criteria in a second. You can facilitate picking up on patients by either screening. So there's universal screening and triage. You can know what to look for signs and symptoms. You could do, screening, targeted screening for someone who's there, as part of a trauma or for a psychiatric disorder, or maybe just young people. You can pick how you want to screen, but screening can be helpful. And then using the PDMP. So in Michigan, it's the MAPS, and just see, has someone been on buprenorphine before? Are they getting a lot of prescriptions? What's their overdose risk? And that can really facilitate these conversations so that you can try to determine what their diagnosis is. So the DSM-5 rearranged substance use disorders and opioid use disorder. And so that now the way that you do it is you kind of calculate how many of these criteria they have. So the 3 categories is loss of control, physiology changes, and consequences of drug use. And then under them, there are like subcategories, so that if they're using more than intended, they're having cravings, they're having unfilled obligations, you basically tally these up. And if they have 2 or more of these symptoms or signs in the past year, then that results in distress or impairment, then they have so 2 to 3 is a mild opioid use disorder, 4 to 5 is moderate, and 6+ is severe. And so once you determine that they have an opioid use disorder, you can put that in their chart. You can then go to the next step and see where they are as far as withdrawal. Because remember, you do not want to start someone on buprenorphine if they're not in sufficient withdrawal, because you will move them from a non-withdrawal state to a precipitated withdrawal state. And our goal is to not harm patients. So if you calculate that they have 8 or more, most pathways say that is enough withdrawal to give buprenorphine on the spot and not cause harm. Some of the older pathways suggested 12 as the cutoff. The clinical opioid withdrawal scale, honestly, I just look it up on my phone. I use MD Calc, and I sit there with the patient and I go through and calculate it with them. It's primarily subjective findings. So they're asking about anxiety, some restlessness, but then it does get into some objective findings as well. Tachycardia. You can look at their piloerection. You can, can see if that restlessness goes from a subjective to an objective finding. And then you just do a score. I do like to have 1 objective finding. So if you have 8 subjective criteria for opioid withdrawal, I may be a little nervous to start someone on buprenorphine, but if one of them is objective, so they're tachycardic or they're having tearing or actively vomiting, and then 7 others, that's probably fine for me. So calculate your clinical opioid withdrawal scale. And then based on that scale, you can do a couple things. If their score is less than 8, you probably want to talk to them about going home with a prescription. Because that way they can wait at home. When they get sick enough that they can't tolerate it anymore, then they can take their dose safely at home. We'll go over that in a second. If their withdrawal scale is 8 or greater, then you can give them a dose right there, sublingual. Make sure they don't smoke or eat or drink anything for 15 minutes previous to you giving them a dose. And you just wait. So we'll go to the next step. Oh, so home starts. Remember, if you're nervous about sending them with a prescription to do this by themselves, this is what your addiction medicine and family medicine, internal medicine colleagues are doing for the patients with opioid use disorder. They're writing them a prescription. The patient goes to pick it up. They give them a guide about how to start it, and that's what they do. And so it's something they do. You can do it. And honestly, the first couple of years, I only gave buprenorphine in the emergency department, and I probably did 30, 40, something like that. But now, almost everyone I see with an opioid use disorder, I offer home inductions, and my numbers have really increased. It's much more common that you'll have someone who is not in significant withdrawal, because the primary goal of most people that use opioids is to prevent going into withdrawal. So if you're seeing them for an abscess or cellulitis or concern for endocarditis, initially they're probably not in withdrawal because they don't want to be. But if you can have a conversation about their use and then give them a prescription, it increases the number of patients that you may be able to capture in treatment. So this will be my time for a case. And so this is a 35-year-old female who came into contact with EMS after a bystander found her down. And she was then given 2 milligrams of Narcan intranasally and kind of immediately woke up. Her breathing was slowed initially. It went up to a normal rate. She woke up and then kind of transitioned into that all too common Narcan precipitated withdrawal with agitation, diaphoresis, nausea, vomiting. But by the time you see her in the emergency department, those symptoms have worn off and she's awake. She's not happy that she overdosed. She's actually pretty upset about it. She's in a hallway bed and she's asking to leave. And so, what can we do before she leaves? I'm going to kind of answer the question for you because I know we're getting a little pressed on time. But what I think would be the best in this case is to, 1, make sure she leaves with an intranasal dose of Narcan in hand. Make sure that if she continues to use drugs, she does so safely or as safe as possible, and let her know where syringe exchange programs are in your community. Offer testing for HIV, hepatitis, syphilis, and pregnancy, and then assess for readiness to start buprenorphine with a home start guide, because she is she's not in opioid withdrawal. She just used probably fentanyl. They got reversed, but now she's back to a steady state. And so she's not going to be sick enough to start buprenorphine for a day or 2. And so you can give the prescription, and when she feels sick enough, she can start it. Here is the California Bridge self-start guide that I often refer to people. And so they just recommend, take a day or 2 to rest. When you feel very sick, basically they say until you can't stand it anymore, then you can take either 1 or 2 8 milligram tablets of the combination buprenorphine, naloxone. And if an hour you feel well, take another dose. So you're typically getting between 16 and 32 milligrams per day. And the next day, you can either take the 16 milligrams that you took or the 32 milligrams you took. And this guide suggests all at once. I think that's fine. Some guides suggest 1 dose in the morning, 1 dose in the evening. We know that the 1 daily dose formulation or strategy seems to have a little bit of better compliance. I mean, obviously people do better taking medications once per day compared to twice. And then it's really that easy. And as I'd mentioned, usually I just say, have you done this before? And they'll say, yeah. And I say, okay, do it just like that if it went well. And if it didn't go well, ask how they did it. Were they sick enough? And you can try to troubleshoot and figure out what went wrong last time. Sometimes you'll hear concern that with fentanyl in the drug supply, it's not safe to start someone on buprenorphine because of the increased rates of precipitated withdrawal. There are increased rates of precipitated withdrawal with fentanyl in the drug supply, primarily because fentanyl is lipophilic. And so even if you haven't used in 6 to 18 hours or 6 to 8 hours or so, you're still going to have some fentanyl released slowly from your fat tissue. And so you'll have this residual fentanyl. And if you do a small dose of buprenorphine, it's going to cause precipitated withdrawal. But what we know is that if you're given larger doses, that will overwhelm the fentanyl in the system, is actually less likely to cause precipitated withdrawal than smaller doses are. Quick reminder, what we're dealing with is an extremely lethal disease. And another way that I like to think about this is, so 107,000 Americans died last year. And every life lost is a tragedy. But we also know that these are often young people with young families in the prime of their life. And so it's not just the number of deaths that's staggering to me. It's when you start calculating years of life lost that it really, I think, more appropriately measures how impactful opioid use disorder has been over the past decade. Here is the California Bridge ED quick start guide. They have a great set of resources, including this one. And so it's all in one sheet. It's really this easy. Someone has been abstinent from opioids, they have withdrawal. If their withdrawal typically is greater than 8, then you can give them a dose, no medications, no labs needed, no IV needed, give them 8 to 16 milligrams. The previous iteration, I think, was 8 milligrams, and they've had some more data suggesting that even higher doses may be better initially. And then if their withdrawal is improved, you give them another dose, and then you discharge them with a prescription until they can follow up. Hopefully your service can provide them direct follow-up, and then give them naloxone. If you go to the right here, if they're not in withdrawal, you do the self-directed or home start as I described. In the middle box here, if they're not getting better, then you have to reassess if, number one, are you potentially under-treating withdrawal? And so if you give them the smaller dose, maybe what they need is actually more because they're a user of fentanyl. Maybe you're missing something and they're also in an alcohol withdrawal, and you need to also treat a second withdrawal syndrome. Maybe they're having some side effects from buprenorphine. It's known to cause some nausea, headache, a little bit of dysphoria, and those will improve with time, but you can offer some supportive care. And then, people are allowed to have more than one thing. And so I remember when learning how to take care of someone with alcohol withdrawal, that the most important question to ask was, well, why did you stop drinking? Because it may be the reason they're in opioid withdrawal is because they had signs and symptoms of endocarditis, fever, chills, malaise, for example, and that you don't want to just treat their opioid withdrawal, but you should also treat their medical condition as well. So kind of looking at other ideas for why they could be continuing to feel sick despite receiving treatment for their opioid use and opioid withdrawal. And then I think Andy's going to talk about precipitated withdrawal more, but if they get much sicker soon after getting buprenorphine, you may have precipitated withdrawal, and typically just higher doses of buprenorphine are what is recommended, but I'm going to let Andy discuss that more in depth. So we kind of talked about a lot of relatively high doses of medications. I think in the literature right now, there's a lot of discussion of microdosing and starting at lower doses, depending if they're on, say they're on Dilaudid for a trauma and they're on it every several hours and you need to switch them over to buprenorphine. There are these complicated dosing regimens in which you can give very small doses to titrate them up as they're on another opioid and not cause precipitated withdrawal. That's not what we're doing in the emergency department. We're starting someone on medication who is in withdrawal actively. And in those situations, in general, you want to give higher doses. And the purpose of this study is to show that you should not be afraid of causing significant respiratory depression with buprenorphine by itself. You start mixing it with other sedating medications such as benzodiazepines or Z drugs, then you can start to have some respiratory depression. But when used as a mono product, even up to doses of 28 milligrams, you see that respiratory rate does not statistically decrease, nor does their oxygen saturation. So don't be nervous if someone needs 16, 24, 32 milligrams of buprenorphine. You are not going to cause any respiratory depression from giving this large amount. On the other hand, giving them a large amount of buprenorphine can actually make it, it's called loading, can make it last. So this is typically a situation where someone doesn't have an ID, right? So they can't get a controlled prescription. They can follow up in clinic in 3 or 4 days. You don't want to make them come back to the emergency department. Go ahead and give them 32 milligrams so that they're safe and stable until they follow up in 3 or 4 days. Or if someone's going to jail, you know that jail does not prescribe or does not administer buprenorphine. If they're in withdrawal before going to jail, give them 32 milligrams. That'll get them at least 3 or 4 days of comfort while their fate is being determined within the court system. Different pathways that you may find show different initiating doses. And I think some of the older ones started at lower doses, 2, 4. And the California Bridge one previously had 8, now it's 8 to 16. These are all fine. But what's not okay to do is to give only that initial dose. So if you wanted to give someone 2, but then get them to 16 milligrams before they leave, that's fine. It's going to take you a longer time. I think there's a higher chance that you precipitate withdrawal doing that, but it's a published way to do it. Just know that if you discharge someone on 2 milligrams of buprenorphine a day, it's unlikely to be enough. It's going to cause them to continue to have withdrawal, continue to have cravings, unlikely to protect them if they use fentanyl, and they can still overdose and die. And so this is a medication where going low or starting low and going slow is not the strategy you want. You actually want to start higher, and then when they follow up, if it makes them too sedated and they don't like it, then they can actually go down. So buprenorphine, start higher rather than lower. And this is why. This is a fMRI study that looks at, I'm sorry, it's not an fMRI study. I can't remember the modality, but it does look at availability of buprenorphine, mu receptors in the brain based on buprenorphine dosing. So with 0 milligrams of buprenorphine, all of your mu receptors are available. You give 2 milligrams, it significantly decreases availability. You get to 16, there is hardly any left. And at 32 milligrams, you have saturation of the mu receptors, which should make them not have a withdrawal and should decrease the cravings for more opioids. So 4th step, after you give them that first dose, to reassess them, see how they're doing. If they're doing better, then I think it's a good idea to give them that second dose, whether you're looking for 16 to 32 milligrams, anywhere in that range is okay. But again, you want to make sure that they have enough coverage to not feel sick until they can fill their prescription that you're going to give them. It's also important because it gives them confidence that, I can actually be on treatment and I don't have to feel sick all the time and I don't have to crave opioids. So this is a bit of a trial for them to see if it's going to work. And if you underdose them, they're going to think this medication doesn't work for me anyways. So go for a higher dose. I apologize. I guess the precipitated withdrawal is in my slide set. So if they get sick soon after being given buprenorphine, you may have gone from that full agonist down to the partial agonist, which is buprenorphine, and have this change, which makes them feel as if they're going into withdrawal. And it may seem counterintuitive, but the treatment is typically more buprenorphine. And so what I like to do before I give someone their first dose is say, there is a 1 to 2% chance that you get more sick after the first dose. And it's hard to predict who's going to get sick. But what I need you to know is that what I will want to do if you get sick is actually give you more of the medicine that made you sick. So try to talk them through that into understanding before they're feeling unwell, and it'll help things along. You can also give a small dose of benzos. I would be a little bit careful because if you combine benzos with buprenorphine, you can lose your airway. And then ketamine in small doses is also helpful. If you have recovery coaches available, social work, get them involved, give them a take-home naloxone kit, tell them a specific time and place for follow-up. That's what's known as a warm handoff, and then give them the prescription of the buprenorphine naloxone combination, either once a day or every 12 hours, as long as needed to get into a local clinic, preferably within a week. All right, I'm going to stop sharing. Any questions?
Any questions? No questions? I got 10 minutes.
Guys, I think
Ready?
that Alan wanted to go forward and look at step 5 one more time. Alan's going to be doing this real soon in his first start. So Alan, if you had any questions, feel free to speak up.
Step on step 5. This one? Does that help? Just need a screen grab.
Yeah, thank you so much. Yeah, I'm gonna so like 2 years ago during COVID, I took the 8-hour X-waiver course, which it was good to take that course. This course is much better, I'd have to say. And I think we're all, protective of our time because people grab at our time with doing this, that, and the other. And something like this, I mean, every ED provider in the country should be taking a course like this because it's, I've had people who have been prescribing this, psychiatrists or some PCPs in the community say like, it's a miracle drug. And I'm like, why are we not doing this? And they were in our, at our staff meeting, they were saying, well, the pain clinic was saying, well, look at all the opioids we're not prescribing now compared to 2 years ago. And I kind of like raised my hand. I said, that's great and all, but, let's not forget about the last, epidemic we've been dealing with, which is the opioid epidemic. And what are we doing to help these people? And it was just like crickets. So now I'm in charge of starting a bupe program. So anyway, thank you guys for these resources. The CA Bridge stuff is fantastic. Although I do know one other thing, it seems all the resources I'm getting, the bupe doses keep going up. It's like start at 2, start at 4, now it started at 8. And so everybody's kind of doing 8 milligrams, it sounds like now for first dose. Okay.
Yep, that's right. And that comes from like increased experience from ED use, right? And doing this more acutely, you're seeing less precipitated withdrawal when you start with the higher doses. And it seems it's a little counterintuitive from what we usually do for most medications, right? Like the lowest effective dose, et cetera.
Yeah.
And this one is like, you got to blow them up. That's the best way to do it. Like just get them from 0 to 60 as soon as possible. Get them feeling better.
I think one last thought, somebody had been talking about like, oh, this isn't a problem, but I just think how many patients have I not treated over 10 years, 12 years, that could have been treated with this. And I feel like kind of bad, that somebody with a huge abscess in their arm leaves angrily and like, we're trying to help them with clonidine and Zofran. It's not working. It's like treating DKA with metformin. It just doesn't work, and now we're using insulin. So I feel bad, but hopeful. So that's good. Thanks a lot, guys.
That brings us back to the first quote. You just have to forgive yourself for the last 10 years and do right because now you know what to do, right?
Sure.
Yep.
Yeah, it's exciting.
I got it. Well, good job, man. Thanks for doing that. I got now I got 7 minutes, so I'm gonna try to hit through. It's 12:30, right? Because I'm gonna head shake. Sarah, is it 12:30 that we're gonna do?
We're
12:30,
probably gonna end up going a little bit over. So
Oh, I can do this.
I
folks
wouldn't
can-
rush. I think it's going to be recorded, and we'll, if people have to leave, then they can watch the last 20 minutes in recording, and that'll be okay.
Well, I'm gonna try to keep it short and sweet and
Okay.
just do my usual. But I think we do have to talk about precipitated withdrawal multiple times because it is going to happen, and it is kind of the cost of doing business, and it's going to happen no matter what you do. And even if you take all the precautions, like you're still going to run into this precipitated withdrawal. And you should also know what it looks like because it's really easy to miss because sometimes people just straight up won't tell you like what is going on. So the naloxone precipitated withdrawal, we've all seen this, and I generally do the trainings for how to take care of opioid overdoses, and one of the things that you could do to avoid this is just go easy with your naloxone dose initially. You die from respiratory depression, so naloxone is like not necessary if you have a bag valve mask and you can establish an airway and ventilate somebody, right? Like you're taking care of the thing that's killing them. And so it's not like a life-saving antidote like once they're in the hospital, like your hands are. Your hands with the BVM, you had spent all that money for medical education to learn how to just do the jaw thrust and put the head of the bed 45 degrees and do that. And so, I don't even reach for a naloxone when they come in after an overdose. I reach for the BVM, and then you can have plenty of time because most patients, like, you can bag pretty well. They're nice and floppy. And then you, again, head of the bed elevation to avoid aspiration, and you start bagging them, and you can talk about whatever you want to. And so it's really nice to be able to do that because it calms everything down. You're taking care of the issue. You can put them on the monitor. You're changing their ABG from 6.7 and PCO2 of 150,000 to like now more of a normal acid base status, right? And so when they come back online, they're not dealing with that huge sympathetic surge. And so you just give small titrating doses of IV naloxone every couple of minutes until they get to that point, right? And it takes, maybe 2 or 3 minutes. It's a slightly longer code, but then you avoid the potential naloxone precipitated withdrawal. Now, as we all work in the emergency department, that is not necessarily the case because they usually get nailed with, 10, 12, 15, 30 gallons of naloxone prior to coming in, right? And then they start waking up as they're rolling in, and then they blow up a triage for you, and you have to know what's going on. And so that's the deal with the naloxone precipitated withdrawal. It's nice because you can actually treat that with buprenorphine if you can get in there. It could be a little bit difficult, but that's one thing. So if they're feeling bad enough and they're with it, and you can talk them through it, you can actually hit people with buprenorphine. And you can give large amounts, like we've been shown over and over again. The respiratory depression has a limit to it, so it's a super safe drug in overdose. And we had a patient that came in last night from a opioid treatment facility, and this highlights a lot of different things. But he was given buprenorphine, has been having kind of withdrawal, and they've been giving him crappy little doses, right? And then so what did we do? We gave him a big dose of buprenorphine and immediately felt better. Right, so we treated the naloxone precipitated withdrawal, and these are places that are, opioid treatment programs, but they still traditionally, like Alan brought up, use like these lower doses that are like keep patients either uncomfortable, don't satisfy the craving, or cause like a little bit of a withdrawal phenomenon for them for an uncomfortable period of time. But then when we hit him with the bigger dose, like you could see him just like settle, and we got to thank you, and we got a sweaty high five because that was part of his withdrawal symptom. He was sweaty. And that's okay, but we did the right thing. And, it's really nice because we see more and more buprenorphine being used in our emergency departments. And like our group and the chief of my hospital made it, required for everybody to feel comfortable with buprenorphine, get X-waivered, and we do some trainings. And so now you see like all of the docs there, and the residents feel much more comfortable being able to treat these, right? And just, it takes a little while because this is a new skill. This is a new way of doing things. Again, like Alan brought up, but it's a really improved way of doing things. And you're just seeing better outcomes for patients, right? You're seeing them treated less horribly. Once patients get started on something in the emergency department, as Arianna brought up, it actually carries upstairs. Like you feel free to put that order in for buprenorphine for them, like as they get admitted to whatever else, right? because, you know, most people are not going to stop that necessarily, like once the order's in there, or they won't look, man, but it's the right thing for the patient because they feel fine. So if you do know that they're on methadone, like you can blow them through a methadone precipitated withdrawal and buprenorphine precipitated withdrawal, lots of buprenorphine, but it's a little messier. It's not really appreciated by the methadone clinics. And I work in an opioid treatment program. So like, I get it. I'm not going to get upset by it, but it can be a little bit more difficult. And again, this is just to reinforce the fact that there is a respiratory, like there's an asymptote there in terms of the depression. Like it is really hard, especially in adults, to overdose somebody. And Arianna and I don't know, we were like having competitive storytelling the other day, and we're like, well, how much milligrams of buprenorphine have you give? And I don't know, we probably lied at some point, right? I was like 100,000, just to make a point. I took all of the pharmacies, and then I made a slurry, and I smeared it all on the inside of them. It's like a horse eating peanut butter. It was crazy, right? But that's what I did, and it was fine. Treatment course. And then the other thing to do is when you start patients on these medications, you need to make sure that discontinuation is not a thing. And that's something that they'll work on in the opioid treatment program, is like, you know, it's people want to sprint through this. Like, I just want to get through my withdrawal. Like I want addiction to be, you know, in the rearview mirror for me. And you have to just start the conversation. And I love using the comparison with diabetes, right? You know, diabetes exists on the spectrum. I mean, we all know some people that just needed some dietary and lifestyle modifications, and then they can stop with medications and they cut out, you know, the donuts and what have you, and then they're fine. They don't need that. And then you have the patients that are in the hospital all the time with DKA, and they can't stay out of DKA for whatever reason, right? And they have their diabetes is up and down, out of control, and they're losing limbs, et cetera. They're having all kinds of badness. And so those are the two ends of the spectrum. And we take care of the entire spectrum, but the vast majority of patients are going to need to be on some medication for a period of time, right? It's not their fault. It's their responsibility to start taking care of the disease process. And that means like chronic medications. And some people, yes, over a period of time, if you stabilize them and what have you, they potentially could get off of it. But you know, there's a good chance that that's not going to be the case. And then it is like any other relapsing remitting disease process. When you compare it with other things like MS and COPD and see it, the same ideas, right? That it kind of comes and goes, and it's something that just needs to be managed. Again, if you look at the data for tapering versus ongoing treatment, if you're working with a place that is all about like, we'll detox you and then we'll get you off of that medication, or if you hear people start talking about that, like you can start pointing to these studies where we know that, you know, getting people through a detox program is actually probably more harmful, and they have like an increased risk of overdose after they leave a detox program. Or you might just ask, like, if they're coming in after an overdose, like, yo, did you go through a detox program recently, or a period of abstinence? Because that's when the overdose happens. They lose their tolerance. And so the goal of a lot of the places that hopefully you'll be working with is to like get them on treatment and keep them on treatment. And like the point of coming back is like, hey, how's it going? Do we got you? You know, a lot of social stuff that once you medically stabilize them, under control, so we can just maintain cruising altitude here. Diversion is another thing that people will bring up, and you know, it's always the same type of phenotype of person that likes to bring up diversion, and they worry about this. And like, I get way less and less concerned about diversion the more data and arguments that I hear about the benefits of it. You know, a lot of people share prescriptions. We share allergy prescriptions, analgesics, antibiotics. We'll just give them to our friends. It's a normal human behavior. We share things, right? We're a communal ape. When you look at buprenorphine diversion, and you know, it depends on how you're defining it. A lot of it is being used for the exact reason you would prescribe it. So like treatment of withdrawal. Like they are trying to not use heroin and they're having withdrawal symptoms. So they'll get like a sub from somebody and hopefully not put themselves in precipitated withdrawal, but you know, treat those withdrawal symptoms just like you would. And if you actually ask these patients, you know, would you prefer to get buprenorphine from a licensed provider? Hell yeah, they would, right? The vast majority of people don't want to have to be finding, you know, their friend to have to get a buprenorphine because it's hard and the supply is like, you know, who knows if they're going to be able to do it. But like this is a signal that there is not enough, and we've talked about this already, that there's not a matching of supply and demand here. And then yes, listen, you can misuse just about anything, right? As a toxicologist, I can tell you that everything is misusable. And so is buprenorphine. But if you let me put it this way. Like if you want someone to misuse a medication, do you want one that has like, that's a full opioid agonist with respiratory depression that's potentially deadly or not? And, you know, we also have to think about the spectrum of treatment for populations of people. Like we can talk about, and Nick already brought this up, harm reduction, right? That's really important when you're trying to keep people alive all the way through treatment, right? And, so, and we take care of all of them as emergency clinicians. So just pay attention to that. Is it, and this is the other thing that's out there, is it replacing one drug for another? Like, do we use the term abuse for these things? And just going back to diabetes, it's just amazing. You know, if you replace the word insulin with buprenorphine or vice versa, in like the conversations that you hear can be amazing, right? So you have someone comes in with opioid withdrawal, be like, we'll treat the opioid withdrawal with some buprenorphine. We don't want you to stay on it forever. Like you don't need that crap in your body. You can do this all by yourself. Like imagine if you talk to a diabetic that way, like we'll get you out of DK with a little bit of insulin, but like that's, you don't really want to be on that your whole life, do you? That's not going to be good for you. So like, let's get you off of that. We can taper it. And then, you know, bada bing. I don't know why I'm all New York right now. But that's the idea here is it's not replacing one drug from another. It's the conflating what drug dependence is and a substance use disorder. We think that, and then people use this in the lay media, and I hear a lot of providers use it, like chemical dependence. You could be dependent on an SSRI. The dependence means that you have a withdrawal symptom if you stop the medication. Like that's all that means. Substance use disorder is all of the other collateral damage that occurs with use, right? And that's, you know, medical hazards, so overdosing, death, you know, endocarditis, et cetera, dangerous usage, running into problems with family and life and work, et cetera, like that substance use disorder. And so, yes, you use these medications that you can to be dependent on and withdraw from to treat the substance use disorder. So like that's a swing and a miss. And then, you know, I'm trying to continue to keep a good clip here, but we need to look for and remove the barriers to treatment. I have a patient that I see, and he's such a great patient. I saw him yesterday because I did clinic yesterday, and he tells me it is so easy to get heroin. You can just drive through certain streets and someone's going to come up to your window and essentially just try to throw bags of heroin in there for a little bit of money. Like that's what you're competing against. And so why would you make it really hard? Like, I mean, I'll give you buprenorphine, but you got to come to like intensive outpatient therapy for 12 to 16 hours per day. I know you got a job, but you got to do that. And then maybe I'll give you 2 milligrams of buprenorphine every day. Like that, what are you going to choose? And so that's the problem with the barriers to treatment is like you have to realize that there's a lot of barrier for people to get in. There's a wait list for a lot of places. There's all that stigma that's associated with it. You know, the emergency department, low barrier. You just have to walk in and someone's got to see you. And that's awesome. And that's why it's really important for us to be doing this. DE regulations, you know, just a couple of things for you to know, that patients admitted for medical or surgical reasons other than opioid dependence. So if they're not admitted to a substance use place, you know, you can absolutely give them methadone. You can give them buprenorphine for withdrawal symptoms, right? In the emergency department, you know, you can give 72 hours of medication. So you can give a go pack, and I'd be really impressed if anybody has a go pack set up. So good for you if you've been able to do that. Or they can just come back every, 24 hours for treatment. But this is why you're doing this, right? Like you don't have to do any training. You can just X-waiver and be able to do that, and et cetera. What I like about this slide is when you have policy and billing and evidence-based care, like they all align. Like, oh, you can get paid extra for doing the right thing and helping patients out. That's amazing. So right now we have a new code, the G2213 is a new billing code for initiating someone on medication and referring them to therapy. And those RVUs are pretty good. Like those are decent RVUs, and it doesn't take a whole lot of time. And it is super, it's super invigorating when you're able to do this. Like you make an assessment of someone, they got them on medication, you can induce them in the hospital or at home. And then you hook them up with the system that you have in place. And then you can bill a 2213 code, and you get a high five and a hug at the end. And I miss those, right? As emergency clinicians, you don't get those very often. So
Andrew,
yeah, what's up, Al? Go ahead.
so that's you would write that up like a procedure note, just like you central line, that way the billers can find it real easy.
Yeah, if you have like whatever your EMR is, make a macro or make a dot phrase or something and put that in there, and then you have that all set, right? And so like some of the partners that I didn't think were going to be super excited about doing this are so excited about the new billing code and the RVUs that you get, because otherwise it was, you just wait for them to wake up and then they go away, right? You give them that list of whatever follow-up places that potentially are out there, but now you can actually do something and have a meaningful conversation with someone, and it's very helpful.
For sure. And we should get paid for doing good medicine, right? And this is good medicine for patients. So that's part of what we do. So real quick, so referral to ongoing care, follow-up after treatment, is that just like the social aspects of like therapy and or Narcotics Anonymous, things like that? And then arrangement for access to support for patients, is that like how they get more bupe through a PCP or whatever? Like, can you explain those two?
Yeah, so ongoing care or follow-up in treatment, this is you getting them into whatever clinic that you designated that you're partnering with, right? Okay. And you have to do, and that's why like making the linkage is important, and that's why having a low barrier access linkage relationship is important, right? So it's got to be, they come in, I start you on bupe or not, and then they, we make an appointment for you, or refer you to their walk-in hours every Wednesday from 9 to 12 or whatever it is, sure. Right? And so it's easy if you have interested internists that have maybe some resident help that always there, that's always a clinic, something like that, or you get family medicine involved. Or if there's already a substance use clinic around you, you could say like, hey, we would like to be able to refer patients to you. Can we have set up walk-in things, or like whatever it is? There's no wrong way to do it. It just should be within a very short, ideally within 72 hours.
Okay.
Yeah. And then, so how do you get started with this? It's, identify a clinical champion. It doesn't have to be one person, it can be multiple. And we're going to have more discussions about this if you attend the next training. Oh, I love that. To be continued idea. It's tantalizing, isn't it? Buprenorphine on formulary. So it's important to make sure that it's in the ED and you don't have to call up to the pharmacy and figure out where it is. That there's treatment protocols that are around that you can print out and you continue to pin up so that everybody can see, so there's no problems. If there's like some diagnostic or screening thing or whatever, like you got to minimize that stuff. Get your group waivered. My group, I'm so proud of my group and my bosses for really pushing this and believing in it. Identify an outpatient referral mechanism. And so just a simple pathway, like the more complicated you make it, the harder it is. If you can get support staff to do it, that's awesome. But it could be just as easy as the doctor calls this number, and then that person is going to answer the phone and say like, yeah, we got you an appointment, or send them over, or whatever it is. It's always good to set up a feedback process, especially when you're doing this new. It's like, hey, you could have done this a little bit differently, but that's awesome. And especially like if you can share success stories with the place that you have developed a relationship with, because you can tell them, hey, remember that patient you saw a week ago? Doing great, wanted to say thank you so much. And clinicians really appreciate that, right? Because we don't get a lot of good feedback. It's usually like, hey, remember that patient that you saw the other day? You get, right? It's never good. And these are actually like really nice things to put out there. And then that's it. There's lots of grants and navigators and other support help. Like there's a lot of people that want this to be successful and are making this successful. So what do we got here? Patient-centered rapid access is essential to care. Increasing numbers that you're starting on and getting them to the community, like that's improving outcomes. You're actually improving, you're decreasing medical usage, you're decreasing ED recidivism, you're helping patients get into care, and this is life-changing for them. And so like making it as simple and foolproof as possible is really important. So this is just the COW score, another quick start guide. All this stuff is on the internet. And so I'm going to finish up with a case that I've been seeing like quite a couple of these recently. We have a guy who is agitated and pacing around the emergency department, diaphoretic, and occasionally alternately lying on the stretcher and on the floor. So there's a lot of movement there. He presented for an asthma exacerbation last night. An overnight team ordered, and he hung around. They ordered some buprenorphine prior to leaving for the day because he was complaining of some withdrawal symptoms. He was irritable, diaphoretic, roaming around, screaming, yawning, rhinorrhea, tachypneic, tachycardic at 138. So what happened? This is a great example of precipitated withdrawal. So it's hard to know if they put a cow score in there or whatever the case was, or maybe they gave like a small little dose we talked about. So this is precipitated withdrawal. You got in there, the person was hooting and hollering and going all over the place. And you took a deep breath and you said, I'm going to be okay. That's the most important thing. It's like, there's a whole bunch of noise going on there and they're flopping and they're making a lot of noise, but I'm going to be okay. And I'm going to be able to get through this because damn it, I am a good doctor. So you talked with them and you said, listen, this is going to sound counterintuitive, but that medication they gave you that's causing the withdrawal, there's a little bit of a bumpy start, but we're going to have to give you some more of it. And then we'll give you some Ativan. And don't bring up the ketamine thing right away, right? You got to say that, put that in the back because they're going to ask for the ketamine first. They say like, see if you can just get away with the buprenorphine. And then if there's like a lot of resistance, then, and we'll give you some lorazepam in the back. Oh, okay. And then if they still got some significant symptoms, you can give some ketamine. But as Arianna and I are in this competition, you can give lots of buprenorphine. And the guy that we saw last night, we gave him 16 and he chilled out, and we gave him another 8 for 24 milligrams total. And he was totally fine after that, right? And he was very much appreciative. And that helped him get over the bump of the kind of mild precipitated, lingering, obnoxious feeling that he had from the clinic that he got referred to, not really clinic, like an inpatient thing. But, you know, that was much better for him. And then, you know, he felt better almost immediately. You saw a turnaround in the person who was really uncomfortable, you know, looking much better. They take a little bit of a nap and they wake up and they're like, ah, that sucked. And you're like, yeah, it's okay. We'll be able to get you those. This is a good medication. And then they realize that now it's a much higher dose in their body and they're feeling better, that they can continue on. And so this guy followed up in clinic, and then he switched over to methadone. I just wanted to put a little spin in there. So overview, this is a highly morbid chronic medical condition. It's highly treatable. So we got to take away the therapeutic nihilism that we've developed over the ages, especially when you're treating with highly effective medications, right? Methadone, buprenorphine are great medications for most patients. This is, you know, a lot of the behavioralisms and the things that turn people off. Like a lot of this is part of the substance use, which goes away once you treat somebody. Like you'd be surprised. I have medical students that come sit in the OTP treatment all the time. And one of the things they said is like, these look like normal to people to me. It's like, yeah, they're normal people. And that's it. Like you came in with stigma and now you're leaving. You can't pick these people from out of a lineup, right? From a grocery store. The ED is super important because we get a huge volume of non-fatal and overdoses that come in, and people that have substance use related disorders and disease, or even primarily coming in for withdrawal, and they don't know where else to go because the healthcare system is so damn complicated. Like, but you know that the ED is always there for you, right? So thank you for doing what you do. And then now it's awesome to see that reimbursement is tied for effective treatment. So we leave it open for discussion and Q&A. For my part, and sorry, I went over a little bit.